Hey everyone, welcome back to another episode of the Brawn Body Health and Fitness Podcast. I'm so glad that you're joining us today. Today I'm joined by Dr. Sabrina Strickland from Hospital for Special Surgeries, and we're going to be discussing a deep dive into the patella, so your kneecap, and we're going to be discussing a variety of different pathologies and things that can go wrong with it. We're going to discuss some different clinical presentation findings from an Alta versus a Baja patella and so much more. Dr. Strickland is a phenomenal doctor and she's very passionate about the patella. She actually co-founded the Hospital for Special Surgeries Patellofemoral Surgical Center. So this is a great episode diving into that, and I know you're going to love it. Dr. Strickland, welcome back to the podcast. I'm super excited to work with you again.
Well, thanks so much for having me. So I think today we're going to talk all things patella. And so the patella is the kneecap. And, sort of to start out with, a lot of patients start having patellofemoral pain when they're teenagers, and they're kind of told, oh, you're a girl, it's just patellofemoral pain. And it's not that it doesn't happen in boys, but it tends to be a little bit more common in girls. And most of the time they're either told, this is normal, don't worry about it, maybe don't do that sport. And sometimes they're actually truly evaluated. And that's ideal because there's lots of different causes of anterior knee pain. And so not all anterior knee pain is actually a patellofemoral pain syndrome. It could be that they have tendonitis. It could be their IT band's hurting, and sometimes that can hurt a little bit in the front, even though it's more lateral. But for these true patellar pain, there's different causes of that. And one of the causes can be alignment. And so if you see somebody who comes in whose knees are a little bit knock-kneed, their hips are a little bit wider, they have some internal rotation of their femur, that can really lead to overload of the patella, and that alone can cause anterior knee pain. And so I think in those patients, physical therapy and sometimes just a off-the-shelf shoe insert, such as a super feet or a product like that, can really help, because that can sort of improve their alignment really simply. And then doing exercises and physical therapy to increase the strength of their hip external rotators and their hip abductors can really make a huge difference. And so, that's sort of like the first category of just the anterior knee pain that you see. I see it in all ages, but I certainly see it in teenagers or young adults.
Yeah, definitely. And you touched on a lot of great things there. I'm excited to kind of break them all down here. So first off, anterior knee pain, as you mentioned, it can come from a lot of different sources. And it's really important to actually get someone to evaluate it and someone to say, here's what I think is going on, because unfortunately, a lot of people will tell you, oh, just avoid that activity or just take 3 weeks off. And then the next thing you know, it's back again. So I'd rather see people from the start and get a handle on it than let a vicious cycle build up over and over and over again, because then it's a lot more difficult to treat from both my standpoint and your standpoint. It's a lot easier when we get to it from the start.
To that point, like at least in New York, you can go direct to a physical therapist. And I think a physical therapist can evaluate how you move, and they can evaluate sort of the source of the pain. But sometimes, especially if it's not getting better, and most states limit how many visits it can be before you actually have to see a doctor. But I don't want to see everybody with anterior knee pain, because a lot of them can be treated without me. They don't need surgery. They don't need an injection. But once you get to the point where you've done some strengthening and a physical therapist has evaluated how you move and you've kind of optimized that, if the knee still hurts, that would be a reason that maybe we need to take a deeper dive and figure out what exactly is causing it. Is it just overload from your alignment, or is there actually a cartilage problem that's happening? And that often requires, at the very least, an X-ray, if not an MRI.
Right. And the alignment piece is certainly an interesting one, because some of it can be structural in nature, where someone is predisposed to a various Q angle. Maybe they're predisposed to excessive internal rotation of the femur, or maybe it's below. Maybe they have increased foot pronation. They have decreased ankle dorsiflexion mobility for whatever reason, and you can't change that. Well, they're likely going to fall into that dynamic valgus position a lot more. It can also be functional. So all those deficits I just mentioned, sometimes we can treat that and correct it. But when it's a structural problem, what would be the best kind of course of action? And I know best is always a subjective thing, but if it's truly a structural thing and you're not able to make any changes functionally, what should that individual look to do?
So let's say they have a structural problem. They actually have real valgus or a significantly increased Q angle. So if somebody comes in and they've had a long history meaning months, and they've already tried physical therapy and they stand in valgus, the first thing I do is I get an x-ray from their hip to ankle because I want to see exactly where the weight-bearing line falls. So I draw essentially a plumb line from the middle of their hip to the middle of their ankle, and it should run right through the middle of their knee. And so, I had a patient today where it's outside the knee joint, meaning they're in so much valgus or so knock-kneed that the weight is outside their knee. That can wear out the lateral aspect of their knee, but it certainly can put a lot of overload on the patella. So that patient potentially is not going to get better with conservative means. They might actually need an osteotomy to straighten their leg. If it's just a Q angle, so it's just a matter of how much, what the angle is between the quad and the tibial tubercle, there certainly are things that can help that, meaning lateral retinacular stretching, strengthening the quad. There have been some studies where they Botox the vastus lateralis to try to really get the VMO. Now, we don't do that in the office. We don't Botox the vastus
I
lateralis.
haven't heard of that one before. That's a new one.
It's really interesting because we talk about VMO strengthening, but most of the data is you can't actually strengthen the VMO. You have to strengthen the whole quad. But sometimes that can really help the way our patella is tracking. But if there's significantly increased Q angle, the way I look at a Q angle is I look at it on an MRI and I actually measure how lateralized the tibial tubercle is. And in a patient who has chronic patellofemoral pain or anterior knee pain due to maltracking, they need an osteotomy. I have to move the tibial tubercle over to improve their alignment. And some of these patients aren't going to get better unless you actually do that.
Right. And you bring up an interesting point with the VMO because a lot of people think of that as being the only medial dynamic stabilizer. They're right. That is the main one. But as you mentioned, we can't just strengthen one of the four quad muscles when they all do the same exact thing. They all extend the knee. And at least from my experience, which is rather limited compared to yours, the amount of times I've had better success with actually going after the hip and doing things to lengthen things like a TFL or kind of reduce the overall need for a strong medial stabilizer in the first place, the better I have results wise. And I think that's largely because of a lot of people forget about the lateral attachments from the IT band to the lateral aspect of the patella. So if you can reduce the lateral pull, then your need for a strong medial pull goes down.
100%. And so when I was training, so I finished my fellowship in 2002, we would do occasionally what's called a lateral release, and we'd arthroscopically just release the tissue on the lateral side of the knee. And it didn't work very well because it was just cutting it. We weren't necessarily doing anything to improve the alignment, but there probably was some subset of patients that actually did well. Nowadays in 2022, I pretty much never do an isolated lateral release. However, if I'm taking care of somebody who has significant lateral maltracking, especially if I'm doing a tibial tubercle osteotomy to improve their alignment, I often do what's called a lateral lengthening, which is a small incision. It's not arthroscopic, but where I can actually release that IT band fascia from the lateral aspect of the patella and then tack it down to the capsule. So it's not leaving this gaping hole, but it's lengthening that tissue so that you don't have that lateral pull. Because you're right, you can try to increase the whole quad strength, but if the lateral side just keeps pulling it out, it's not going to make a big difference. And so not just strengthening the hip, but stretching the whole lateral side, I think, is incredibly important.
Definitely. And I've always wondered, if you're going to do something like a lateral release, how do you know how much to release?
Well, you don't. And that's the thing, because you kind of cut it or you don't. You can't partially cut it. When you do a lateral lengthening, you release it and then you reattach it. So you kind of essentially what you're doing with the lateral lengthening is you're centering the patella and then you're seeing where the tissue lies, and you can sort of reattach it in an appropriately lengthened position. So we've really gone away from lateral release and gone to lateral lengthening. But again, lateral lengthening is usually done in the setting of realignment. It would be very rare to do an isolated lateral lengthening.
You mentioned again about the quadriceps strength not being the main thing that would correct something like that malalignment. And my mind went back to initially when you threw out the term patellar tendinitis. If we just keep loading the quad on a patella that's already pissed off, for lack of a better way to put it, we're probably not going to make good strides in resolving pain. If anything, we might increase how pissed off the patella and patellar tendon is from repeated quad loading over and over again. So that's something that, as I mentioned, that's something I've kind of shifted away from here personally and more towards the model that we were talking about of more of like a regional interdependence kind of approach. And I'll even go as far to say that overall core and pelvic stability can play a role in patellofemoral disorders. And there's even a clinical prediction rule that shows that lumbar spine manipulation can improve patellofemoral outcomes, which that goes in a whole nother direction. But it's just interesting to me how everything is so interconnected. And while we typically think knee pain, look at the muscles of the knee, we really have to look more globally, in my opinion.
100%. And a few years ago, I saw a physical therapist was giving a talk at HSS where I work, and they were showing somebody walking up is some kind of stair climber, and they were either using their quads or using their hamstrings. And so that didn't make sense to me until I sort of saw this video, because one of the things, if your patella really hurts or the anterior part of your knee hurts, you can sort of avoid your quad and you can use your hip flexors instead. And so you can bring your leg forward with your hip flexors and then just use your hamstrings to bend your knee, which your hamstrings do bend your knee. But that's not the right thing, because your quad just gets weaker and weaker by doing that. And so, a lot of times when patients kind of are working on their quad strengthening, it hurts their knee and it doesn't really work. And so part of, improving your gait is figuring out what you're doing wrong without overloading it. And so if you were trying to make your quad stronger because you had a patellofemoral problem by just doing step downs, you'd probably be miserable, because that would just exacerbate the problem. Yes, in isolation, your quad would get stronger, but it overloads your patella. So it's kind of tricky figuring out how to make it stronger without overloading it. And I think sort of fixing all the joints around it as best as you can, whether it's a pronated foot with an orthotic or a weak hip by strengthening the hip, I think is incredibly important, because you can't always fix the knee.
And a lot of this comes back to observation. So watching how someone moves and watching how they do functional things that they have to do every single day. And one of the things I feel is often missed in observation is the patella itself. Is people don't really look at, is it higher than the other? Is it lower than the other? Where is it positioned? And I know that's a huge passion of yours. So what does it mean if, one kneecap is slightly higher than the other, slightly lower than the other? Like, what would that mean from a examination and clinical finding standpoint?
Generally, patella alta is how you're born, meaning you're born with your patella high. And when you're born with a patella alta or a high patella, first of all, you're much more likely to develop instability, because it means that you have to bend your knee more to get the patella into the trochlear groove. So just inherently, it can predispose you to instability. And it can be symmetric. Most people have bilateral patella alta, but certainly sometimes you'll see somebody in the office, you'll just have them sitting on an exam table, and when you look at their knees, they don't look the same. And that can be just because one patella is sitting higher than the other. What else can happen if you have patella alta? So the patella is a pulley. So you pull on your patella with your quad, that then pulls on your patellar tendon, that pulls on your tibia. And if your patella is high, instead of all that force going through your patella, which is what it's there for, it can preferentially load your fat pad. And it's typically the inferior, just inferior to your patella on the lateral side. And you can get what's called fat pad impingement. That can be pretty disabling, meaning patients can have a lot of anterior knee pain. They They typically are in their teens or 20s. They'll have all the typical patella symptoms, meaning pain with stairs, pain with jumping, pain with any type of impact, pain with sitting in one position for a long time. And what I get to see, because I get to get the MRI, is the fat pad, which should normally be black on a fat suppressed sequence, will show up bright white. And we can measure the sort of the rate, well, it's a ratio between the patellar articular surface and the distance to the tibia, and it should be 1-to-1. And some of these patients have 1.4, 1.5, meaning it's sitting 40 or 50% higher than it should. And that can be a real problem. And certainly the first step is typically go to PT, see how you're moving, strengthen your quad. But for some of these individuals, the only way to fix it is to actually distalize it, to put the patella where it's supposed to be. And that's a different type of tibial tubercle osteotomy. It's one that patients typically, at least in my experience, recover from quite quickly, but that's also because I do a lot of them. The way I do it is pretty minimally invasive. I would say when you look around the country for a lot of surgeons, that's a surgery with a fairly high complication rate, not in my experience, but it can be a very successful operation. The opposite is just as bad. So patella alta can overload the fat pad, you can get patellar tendinitis. But if the patella is too low, that can be equally bad. But it's pretty rare to have BAHA or low patella unless you've had surgery. Usually those patients are after BTB ACL surgery or a patellar tendon repair where it scars in too much and their patella ends up being too low. And that can be equally catastrophic or worse.
Interesting. So you mentioned with the BAHA, it's typically after surgery, and it's typically you've referenced the bone patellar bone ACL procedure. I know we talked previously about how you do ACLs, and you typically do a hamstring graft. Would grafts from other locations instead of the patellar tendon, or I'm seeing some quad tendon grafts even now, would a quad tendon graft decrease that patellar BAHA chance? Yeah.
Yes. Yeah. So I do either hamstrings or quad tendon almost universally, but that would be very unlikely. I've seen patella BAHA after tibial tubercle osteotomy. I've seen it after a tibial fracture where patient had significant trauma to the knee. It's one of the reasons that we want patients after any type of surgery to start moving their knee immediately and get their quad working. I had a patient who had a femoral nerve block and had nerve damage, and so her quad just really couldn't fire, so the patella kind of fell down and then stayed down. I just saw a patient who had a patellofemoral replacement and ended up with severe BAHA. So there's a lot of different reasons, but most of them involve trauma or surgery that results in patella BAHA.
Interesting. And then going back to the Alta now, I'm sorry, I'm switching gears a little bit. On the Alta, you mentioned about the fat pad syndrome, fat pad impingement that can occur. Outside of the MRI findings, is there any real way to differentiate that from, say, something else like a patellar tendinitis on a objective examination, or are you more reliant on the subjective findings for that? Or if you couldn't use the MRI, what would you look at?
So I think on exam, so patellar tendinitis tends to be central proximal patellar tendon. Tends to be right in the middle of the tendon. So if you're in the office and you're evaluating somebody, they have pain with running and jumping and their tenderness is central proximal patellar tendon, usually patellar tendinitis. For fat pad impingement, it tends to be just the lateral border. So just the inferior lateral aspect of the patella, when you're palpating over the lateral patellar tendon or even just lateral to it, that's pretty classic. Patellar tendinitis, it doesn't really happen unless you're a runner or a jumper. You'll see it in volleyball, you'll see it in basketball, you see it in runners. If somebody comes in and they're not doing those sports, it's not patellar tendinitis. I saw a patient today and they told me, oh, I've had this history of patellar tendinitis. Usually, if it's been going on for years, it's not patellar tendinitis, it's something else.
Right. And the only other population I'll add to that is those post-op ACL patients with the patellar bone graft, usually around 3 or 4 months when you start all of the jumping, all of the force absorption, the return to run preparation. When you restart that, the fact that they're missing a third of that patellar tendon in most cases usually causes a little bit of irritation, which can make that all the more fun to work through.
Yeah, 100%. One of the reasons I personally don't love the patellar tendon for ACLs.
Right, right. So as you were talking about Alta, you mentioned that can contribute to instability of the patella, and that's something I've actually seen a lot more of lately, where I've got people sitting in full extension. I can move their kneecap all over the place. They can, unlock it at like 20, 30 degrees flexion, open pack knee, and I can still move it all over the place. And it gets to be kind of concerning for me because it moves a lot more than it should. So from your side of things, from instability, one, how would you measure that objectively? Do you like kind of like a quadrant excursion, or how do you like to measure patellar mobility itself? And two, what do you do about a hypermobile patella?
So, I mean, a lot of patients are just ligamentously, like especially these Alta patients, but are ligamentously lax. So, if they come in without a history of instability and have a lot of mobility, I don't get very excited about that. I mean, I'm looking at something else. I might look at fat pad impingement. If they have a history of subluxation or instability, they usually have apprehension. So when you laterally translate their patella, not only does it move, and I think the quadrants are hard to sort of assess. If a typical normal knee is somewhere around 2 quadrants, medial or lateral, it's moving a couple centimeters. The whole patella is usually somewhere around 38 to 45 millimeters. So it's moving 2 centimeters. That's sort of typical. But if somebody moves and then they don't have an endpoint, that's a little concerning. But without a history of instability, I don't get too excited about that. But it's more that if you translate them laterally and they start getting nervous, they have an apprehension sign, they're reaching down and grabbing your hand. I look at their face when I do it. I don't look at their knee. That's a patient who probably has instability, and they probably know they've had instability when they come in to talk to you. Sometimes if it's acute, patients will think they tore their ACL, or the trainer thinks they tore their ACL. I put my hand on their knee, I translate their patella a little bit, and they're jumping off the table. That doesn't happen with an ACL tear. I know right then that it's a patella, not an ACL.
Right, right, definitely. And that actually takes us perfectly into the talk on MPFL procedures. And that's actually where I first got to know about you. Was you've written some articles and done some YouTube videos on the MPFL. And when I was in school for my doctorate of physical therapy and I saw my first one, I was like, I need to find out more about this. And you were the first one to show up on Google, believe it or not. But I found your stuff very helpful, by the way. I should throw a little plug in there for that.
Well, thank you. I mean, when I trained, we didn't do MPFL reconstruction. So,
Really?
everybody's heard of an ACL, but nowadays it's becoming more common. It's still, I think there's a lot of technical issues like there were when we started doing ACLs, meaning I see a lot of MPFLs that didn't go so well. And why is that? Well, we only are good at things we do all the time. So whereas I do, hundreds of patella surgeries a year, some people might only do 1 or 2, and getting it in the right place. So what is an MPFL? An MPFL is a really wimpy ligament that stabilizes the kneecap. And it's not built to really restrain your patellar translation particularly well. And in most patients, that's okay, because if you don't have Alta and you're not particularly stretchy, your patella engages in the trochlea and you have bony restraints. But if you don't have particularly good bony restraints, meaning your patella is high or you have trochlear dysplasia, so it's a little bit flat, you rely a lot more on the MPFL. And so I think it makes perfect sense, because we've been doing ACL reconstruction and we've been doing MCL reconstruction for posterior lateral corner for a long time, that we thought maybe we should make a better ligament there. And so a lot of the research has been done on, well, where does the MPFL actually attach? And that's one of the problems, is that it's not like one single or double bundle like the ACL. It's not a structure that you see when you're operating. Like, for example, if you're doing a knee replacement and you cut open the medial side of the knee, you don't see it. It's not like this identifiable band. It's more like a more fan-like structure. And so that's part of the reason that we didn't think, well, that's my guess, to reconstruct it 20 years ago. And as we became more aware that it's really not great to have recurrent patellar instability, and we're looking for an answer, we started reconstructing this ligament. And so, some of the data has been, well, where's the best place to attach it? Because since it's not this discrete ligament, or we're not born with a discrete ligament. And basically what's been determined is anywhere on the top 50% of the patella. And in some cases, we actually wrap it around the quad, and some people just wrap it around the quad. But where does the native ligament attach to? It attaches to the superior 50% of the patella, and then there's some fibers that go into the quad. So it's a pretty broad attachment. Initially, when we were doing it, we were usually using autograft, usually a hamstring. The data says it's about the same to use an allograft versus an autograft. So from the vast majority of patients, I tell them, well, I don't have to weaken your hamstring. I don't have to add an extra scar. So I'd personally rather, if I were you, I'd have an allograft. So usually we use donor tissue for it. And then how you attach it to the femur is kind of dealer's choice. I usually use a button, the same I use for an ACL, but you can use a plastic interference screw, and it's just a matter of getting it in the right spot. And when I say I see a lot of MPFLs gone awry, it's because it wasn't attached to the right spot on the femur.
You literally answered what was going to be my next question, though. You got ahead of me on what you used for the graft. And I was thinking, too, a lot of those medial knee structures, the MCL historically, but I believe the MPFL as well, correct me if I'm wrong, has the capacity to heal itself to a certain extent following a traumatic sublux or dislocation. But it's going to heal in more of like a lengthened position than it would originally.
So you're right. So the MCL usually heals just fine. I mean, if it's a higher grade injury, we tend to brace it so you're not stretching it while it's healing. The MPFL, because it's an extra articular ligament, unlike your ACL, it's sitting outside the joint. So it certainly can scar back in and heal. So if we see a person who's dislocated once, who has good bony alignment, we typically rehab them. It's the patients who have patella alta and their patellas and an increased Q angle, or what we call an increased TTTG, where their tibial tubercle is sitting significant laterally and they're still growing. There's studies that say 70 or 80% of these patients will redislocate, and we're worried about cartilage injury. So those are the patients we say, you know what, maybe have surgery after one. But many patients can get away without surgery because depending on how everything else is aligned, your recurrence rate might only be 10%. And so certainly you don't want to have surgery if there's a 90% chance it's not going to happen again. So
yeah, definitely.
It's a very varied group that this happens to.
I love this conservative first treatment model we keep bringing up over and over again. It's something that you've mentioned, Dr. Dries we've had on, he's mentioned it as well. It seems rare for me to find a surgeon who is saying, hey, surgery might not always be the best option for you. So
right. Well, surgeons, we like to operate, but, certainly, I mean, ideally we have enough patients who actually need surgery that we don't want to operate on people who would have been fine without us. And
right.
So
going back to the MPFL, from a rehabilitation standpoint, I've seen a variety of different protocols or guidelines on what to do, what not to do. And typically I'm seeing something like avoid flexion past 90 degrees for the first couple of weeks. Avoid a whole lot of aggressive quadriceps type stuff early on in like the first week, but get the quad back fairly early. So like week 2, 3, 4 usually is when surgeons are typically saying, hey, you need to chase the quad now and get it back quickly post MPFL procedure. Do you usually suggest similar guidelines, or what are things that you're looking for from a rehab professional post MPFL procedure?
So I think our original protocols did limit flexion, but it actually doesn't make any sense, because if you put the MPFL in the right place, it should loosen past 60. So there's actually no reason that we're limiting flexion to 90. So at this point, I encourage flexion, as much flexion as possible. Now, if you have a swollen knee because you just had surgery, you're not going to flex to 140. But and then as far as the quad, how you look at 4 months is how well you've done as far as getting your quad strength back. So I want the quad firing immediately. I mean, I want quad sets on day one. The only thing I really worry about after an MPFL is that I want the their effusion to be gone before they ramp things up. And the ligament's going to take 3 or 4 months to really remodel at a minimum. So I don't want them doing anything dangerous. So of course I don't want them cutting or twisting or dancing in the first few months. But as far as quickly getting on a bike and moving the knee and doing quad strengthening, I don't really think there's any reason to wait.
Right. That makes a lot of sense, actually. I hadn't thought about the flexion precaution kind of becoming irrelevant in some cases, like you mentioned. And I guess the only other thing that came to mind for me is probably not a good idea to do lateral patellar mobilizations on a fresh post MPFL. I can't imagine why, but
right. That wouldn't be the best idea. I mean, ideally, we've put it in the right place, which means it allows some lateral patellar translation. But just like if we're rehabbing a shoulder instability, you don't want to bring it back into the position of dislocation when you're trying to get that those anterior structures to heal. The same thing for a patella. I mean, doing proximal distal mobilization is fine, but doing lateral translation, probably not a great idea at the very beginning.
It becomes a question of why are you even doing what you're doing? Because I've seen cases where some people just kind of automatically do things without thinking about them, and that kind of makes me concerned. I think every action needs to have a purpose, whether that's an exercise, a manual therapy, or whatever you're doing. And I would say the same is true surgically as well. Like, before you do something, you probably think, do I really want to do this? Or even if it's a conservative management, like a injection, I'm guessing you probably say to yourself at some point, hey, this is actually going to help. Hence the reason I'm going to do it, not just, let's just shoot them full of PRP and see what happens.
Well, actually, a patient asked me today who has patellar instability, and she said, oh, a friend asked about PRP. I said, I think PRP is great for early arthritis, or even if you want to try it for more advanced arthritis. I think it's great for chronic tendonitis. For instability, PRP doesn't make any sense. I said, it's not only that it would be a waste of an injection and your money and a procedure, but it doesn't make any sense. Like, how would platelet-rich plasma that can help promote healing, it's not going to shorten your MPFL.
Right.
And that's sort of what we're asking of something like that in that situation. And on the same sort of topic of MPFL, I do see patients occasionally who are recommended to have an MPFL who don't have instability. MPFL is a surgery just for instability. It doesn't work for anterior knee pain. It doesn't work for overload. It doesn't work for maltracking. And MPFL surgery is only for instability. So when a patient's recommended to have an MPFL, but they don't have instability, I get concerned what their doctor was thinking, because it just like you have to evaluate a patient in clinic and think about whether you're doing patellar mobilization when they just had surgery to stabilize their patella. The same thing as the doctor shouldn't be thinking about an MPFL if they don't have instability. It doesn't make any sense.
Right. And I guess going back to our point on just overall observation and assessment, I guess I would say, is there something better out there to accomplish the goal that you want to achieve? So, if you take rotational instability of the knee, and you're saying MPFL, then I guess my question would be, could there be something else like a ALL that could potentially help with rotational stability of the knee instead?
Yeah, I mean, if it's rotational stability, that gets into a posterior lateral corner / ACL.
I might have went too far off the edge there.
And I mean, that can get, but generally, if it's rotational instability, more like they have femoral torsion, then it would be asking a whole lot of that MPFL to bring the patella over, because the patella, that's a restraint, but it's not supposed to pull it over. And so those are the failures. That's a lot of the failures I see of MPFL, that they needed something more than an MPFL. And again, I had this conversation today with another patient saying, sometimes the conservative thing is to do surgery. Meaning, if you're malaligned and you're having a recurrent problem, you've already sort of, to me, exhausted conservative treatment, but also the conservative thing isn't to let this keep happening, is to fix your alignment or give you a actual restraint so that this doesn't, continue to happen.
Right. Do something to kind of stop the vicious cycle, especially if it
Exactly.
continues to happen over and over and over again. And I know you've seen patients, and we were just talking about one before we started recording, actually, of, 4-year history, 5-year history of recurrent problems, and it's just not getting addressed. And ultimately, we kind of have to put an end to that cycle because, I'm miserable if I feel off for a day. I can't imagine feeling off for 4 or 5 years.
Yeah, 100%. And like, why, I'm not 100%. I don't know why this was sort of an ignored topic. I mean, back when I trained, so we didn't do MPFL, so we would do what's called a medial imbrication or a VMO advancement, where we just kind of put some sutures in the just medial to the patella. We were kind of trying to cinch it together. The problem is as I described that sort of fan-like structure, it's wimpy. It's not very strong. So you can sort of cinch it up, but it worked in some patients, that got really stiff and they were worse. And in many patients, it just didn't work. And so I think the part of the reason for delay is that, so many of these kids just stopped doing sports and then they were sort of okay and it didn't happen very often. And so the attitudes like, oh, you're fine. You don't need to do that sport. A little bit of this was Title IX. I mean, Title IX's been a long time now, but girls weren't doing a lot of these sports, so it wasn't such an issue. It's much more common in girls than boys. And I think the old generation of orthopedic surgeons were kind of like, oh, you're a girl, it's okay, you don't need to do sports. But a lot of these patients have patellar instability just doing day-to-day activities. Like they're not, they're 32 taking care of a baby and they just twist their knee a little bit and their knee gives out, or they're working at an office and they just kind of shift their weight and their knee gives out. And like, that's no good. You can't have your patella dislocating at, working at a bank.
Yeah, that's not normal. Not normal at all.
Exactly.
As we start to wrap up, I know you also have a strong passion for skiing. Have you seen any interesting cases of skiers and patellar disorders, or is that kind of a unmatched pairing?
No, it's actually pretty common. I mean, one of the things about skiing is you're kind of in a little squat the whole time. You're not skiing with your legs straight. And a lot of skiers have ACL injuries. And so like how does that all interplay? So I mean, my kids all ski raced. I ski raced in high school. It's been, I have a lot of friends and patients who are avid skiers. And one of the things we see down the road after ACL surgery is you're much more likely to have patellofemoral problems. And some of it we understand, for example, like we talked about, if you had a patellar tendon, you maybe had some persistent quad weakness, you overload your patella, they're much more likely to have anterior knee pain. But we also see a lot more, or it's much more common to see anterior cartilage injuries, both trochlear cartilage pathology and patellar cartilage pathology. And these, so I have a bunch of patients who've developed arthritis underneath their kneecaps or a cartilage defect, and that becomes more symptomatic skiing. So the treatment for them can range from everything from a cartilage transplant to a patellofemoral replacement. But generally, patellar problems tend to be symptomatic in skiers, less so instability, more so overload and cartilage problems.
Right. And you mentioned the racing population. I would imagine if there was something more along the lines of instability where there is some kind of dislocation, I would imagine that would be more on the like jumping side of skiing, where there's a jump, land, and more potential for things to go wrong.
I mean, just thinking about it, I haven't seen a whole lot of skiers with patellar instability. I see much more with cartilage issues or overload in skiers. But what I definitely see is the 30+ year olds who tore their ACL in their teens or early 20s, and now they're 30 with having had ACL surgery and now have a patellofemoral problem.
Gotcha. Interesting. Well, Dr. Strickland, I think we've covered everything from osteotomy procedures to instability to non-conservative management, or conservative management, non-conservative management, and all these different amazing points along the way. Do you have any kind of closing thoughts, closing remarks, or anything that we missed that we didn't touch on?
I think my only closing remark is if as a physical therapist or as an athletic trainer or as a patient, it's not normal to have knee swelling. So, it's not normal to have pain. And we've talked about, you shouldn't have chronic pain, period. But it's definitely not normal to have swelling. And once you see swelling, you really need more imaging. I mean, it's swelling 100% buys you an MRI in my practice because there's something more going on. This isn't just a little tendonitis or a little bit of overload if there's swelling. So I think swelling should really tip you off that something more serious is going on.
Yeah, definitely. I like that point. That's that and the other one I found is everyone kind of responds differently to pain. So trying to use something other than just palpation. So I like the tuning fork or different things like that to try and get more information about what's going on, because palpation can only tell you so much at the end of the day.
True. And some people have no tenderness to palpation, but are pretty limited in their activities of daily living.
Dr. Strickland, for people who want to find out more about you and your work or check out everything that you're doing up there at HSS in New York City, where can they find out more about you?
So there's a ton of information on my website, which is just sabrinastrickland.com. But and I co-founded the Patellofemoral Center at HSS. And so we've made a bunch of little videos just explaining different types of surgery. I've done a million posts about different things or commenting on articles. And, my goal is just to educate people, both, I want to educate patients. I want to educate physical therapists. I want to educate other surgeons, because ideally we sort of solve this problem. I mean, I'd like this to not become a chronic problem for anybody.
Right. Put an end to it while we can.
Exactly.
Like that. I like it. Dr. Strickland, it was great having you on again. Thank you so much for your time, your knowledge, and your expertise. We really appreciate it.
My pleasure.
Thank you so much for listening to this episode of the Brawn Body Health and Fitness Podcast. If you liked this episode, please make sure to share it with a friend, subscribe so you don't miss any of our upcoming episodes, and leave a review. This way we can spread knowledge and motivation and help reach more people. Thank you again for listening, and I'll see you next time.